So where are the sites of infection? Again, we all know this. There's three major areas. Nosocomial pneumonia, ventilator-associated pneumonia most typically in the ITU. Bacteremia, often arising from central venous lines and arterial lines, but it's worth remembering that a lot of bacteremia we see doesn't always come from CVCs. It can come from VAP, commonly caused, not uncommonly caused by gram-negative bacteria, but also this category, the surgical disaster as I call them, patients that have had all sorts of problems on the ITU, on the general surgical wards and are now coming to ITU for intensive support. VAP, I mentioned, obviously is one of our patients there, as you can see, and the sort of organisms they get. Well, they will get Klebsiella, they will get Pseudomonas, maybe Enterobacter, and even sometimes E. coli. What about this abdominal wounds, abdominal surgery? I've got another quiz for you, and I'm not going to tell you the answer. Patient on ITU a little while ago, on our ITU, with some very characteristic clinical signs here. Anyone like to hazard a guess as to what the underlying condition this patient had? Pancreatitis, absolutely top prize there, yes. You have the classical Gray-Turner sign, discoloration of the lateral flanks, and there's some ascites there as well. Very difficult patients to manage, very difficult in regards to infection. This is rather a nice little study, which I saw at the 2007 Infectious Disease Society of America meeting, and it's looking and following the clinical and economic consequences of failure of antibiotic therapy in just the sort of patients I've just shown you, those with serious intra-abdominal infections or complications. And this is an American-based study, very aggressive early therapy meant that 3/4 of those patients responded. A quarter of patients didn't respond, and typically those were patients that did not get the correct antibiotic initially. What happened to them? Bad things happened to them, very bad things. Three times the death rate versus those that responded to initial therapy. We know this, we know those patients, you don't get them right at the beginning, they go wrong. And those that survived had twice the length of therapy and twice the length of stay. So not good. What sort of organisms are we encountering on our intensive care units? Well, this is a very nice, very comprehensive study from Ron Jones's group. It covered USA and Canada, and I put USA and Canada on there because it's sometimes nice to compare them. They're similar but subtly different, and also had some European data. The European data I'm not showing because it actually was the same as the USA and Canada data, and I suspect a lot of the same sort of organisms are encountered in your units. Top of the pops was Staph aureus at 20% or 17% in Canada. Next followed coagulase-negative staphylococci. But a lot of those infections, of course, are line infections, and changing the line or a quick short course of vancomycin inevitably cures those. So they're out of the way. The next villain to appear on this top 10 of sort of criminal bacteria in the ITU is Pseudomonas aeruginosa. It's number 3 in the USA, it's number 4, interestingly, in Canada. Interestingly, their overall rates of infection in ITUs in Canada were lower than the USA, and we might speculate about that, why that might be. But once we've got clear of Pseudomonas, what do we hit next? Well, we hit the Enterobacteriaceae. We've already had that term mentioned, and it's a term we microbiologists use to confuse you clinicians. It's basically a long word which means coliforms. You know what coliform is. And there's E. coli, Klebsiella, Enterobacter, and Serratia are the top 10 ones there. But if we lump them all together and think of them as a group, because they are very similar, they all live in your guts. As we stand here in this room, everybody in the room has Enterobacteriaceae, has E. coli, Klebsiella in their bowel. And it's 1/3 of all infections, so they're very important. Which, if you remember, brings me back to a point I made earlier about what is the colonizing flora resistance level in India. It's different to many other parts of the world. You have a very high rate of ESBLs. About 1/3 of your patients who already have ESBL, Enterobacteriaceae in their gut. So when bad things happen to their gut, the surgeons stick knives in them, they'll spread, they'll cause peritonitis and septicemia caused by ESBLs. That's why you see a lot of ESBL infections. It's nothing to do with necessarily bad cross-infection control. That may be a part, but it's actually you're facing in your ITUs a fundamental problem that's generated out in the community that's coming into you.